What obstacles were the hardest in Kruz's stem cell transplant?
I think that the biggest obstacle really was to identify the right combination of the drugs and the right dose that can allow the engraftment without giving them too much toxicity. And with Kruz, this worked very well. And I think that the plan that we made with Kruz, of course, can be optimized because everything can be always optimized, but is a real good backbone which guarantee us the best engraftment rate with the minimum toxicity for the patient.
Were there any complications you weren't expecting?
Let's say I think that Kruz is really a special child, and also he has a special parents, which render everything much easier. I probably expected more complications than the one that we had. We were ready to the worst case scenario, and we probably had this best case scenario because he didn't have infections, he didn't have almost fever, he had normal complication on the lower range, I would say, that the patients receiving a stem cell transplant got. So with him, everything was pretty smooth.
So are you very proud of how the transplant turned out for Kruz?
I am honestly very proud, yes. I don't want to speak loud still, because anyway, it's something very new. And I know that every patient is a different patient, and especially in this syndrome, I think Kruz was in the ideal situation for receiving the transplant, and maybe for other children is not the same because maybe they have already vascular complication or other kind of problems. But thinking about how it did go so far, I mean, now we are 4 months after the transplant. He has been discharged 38 days after the transplant, and every time I see him, it's just a joy because he's doing super well.
Will Paizlee's transplant be the same as Kruz?
With Paizlee, we just have a little difference because with Kruz, the bone marrow was very, very hypocellular. So usually our cellularity in the bone marrow is around 80-90%. In Kruz, this cellularity was lower than 10%. This is what we call bone marrow failure syndrome, which is part of the SIOD. That means that even if we use low dose chemotherapy, the likelihood that the transplant engraft is very high. Paizlee cellularity 3 months ago was 40%, which is still very low, but not so low. So with her, the biggest challenge will be, again, the engraftment. So I am thinking about combining maybe another drug at low dose in the conditioning regimen, just for making sure that the engraftment will be the same. And my plan is probably to repeat the bone marrow aspirate before starting this transplant, exactly for making sure that the cellularity didn't go farther down. Otherwise, the rest of the plan will be the same. Even if she's not on dialysis, I am planning to do the pharmacokinetic analysis of the drugs that I'm going to infuse, because her renal function is not fully normal. So she can have anyway more drug recirculating on her blood after the administration of the chemotherapy. So I want to make sure that we know exactly how much drugs we are infusing her.